Welcome to Grow Them Right, podcast where we discuss how to prevent health issues from infancy. I'm Dr. Roche, a dentist and a mother of two. As a dentist, my expertise are in oral health, and I'm committed to continuing education. I also have a keen interest in preventative health. So in this podcast, I ask questions of experts, explore their insights, and discuss practical tips on how we can help our children grow healthy and strong right from the start. The whole idea for this podcast is to elevate the conversation and allow you, the listener, to make more informed decisions. I need to emphasize that these podcasts are not a substitute for medical advice. If you have any specific health concerns for you or your loved ones, please speak to your own medical professionals. I hope you find this space useful, and if you do, please take a second to subscribe and share with your friends. And together, let's grow them right. Hi everyone, welcome to Grow Them Right. Today I have the honor and privilege of having Dr. Nour Taraf here. Dr. Nour is a specialist orthodontist, practices in Sydney, and he recently finished his PhD on maxillary growth modification. He will explain what that is in a minute. Now, I'm very familiar with Dr. Nour's work and his passion about growing our children right, but I've actually never met him before. This is my first time, and I'm very excited. Welcome, Dr. Nour.
Thank you. Excited to be here.
Thank you. So tell us about what is maxillary growth modification?
So that's actually been an area of interest of mine. And when we're talking about maxillary growth modification, basically the maxilla is the upper jaw. So we're talking about development of the upper jaw, because for us as orthodontists, it plays a big role in obviously the space for the teeth, but growth modifying the maxilla itself or the upper jaw has other implications as well, as the upper jaw and the nose are actually the same structure. Mm-hmm. So hence it plays a big role in how our children develop.
That's very interesting. So it is one single bone that actually makes our nose and our upper jaw,
You can
correct?
say pretty much, yes. Mm-hmm. The maxilla or the upper jaw is the same. The nose is part of that, or the nasal cavity is part of that bone. And the bone is actually made of two sides, left and right. It's actually two halves. Mm-hmm. Yes.
And joined in the middle, basically,
yes.
by
a suture.
What we call a suture, where the bones join together.
Exactly.
So is that then correct to say that orthodontic treatment is not just about straight teeth and a big smile? There's some health implications also when it comes to orthodontic treatment.
Absolutely. I think especially when we look at now how modern orthodontics is moving, a lot of the issues related to the teeth are not necessarily a problem of the teeth as such. So for example, when you're looking at crooked teeth or crowded teeth, well, why are the teeth crowded? Mm-hmm. Well, the teeth are not necessarily too big for the jaw. It's actually the jaw that may have not grown enough to accommodate the teeth. And if the jaw hasn't grown enough to accommodate the teeth, well, what's on the other side of the upper jaw is actually the nose. Perhaps that hasn't developed as well to accommodate the breathing needs of that child. And so we find now that the jaw structure is not just about the smile and the teeth. There's actually a lot more to it than maybe we used to approach.
Very, very interesting. So growth modification means that you can actually modify this growth.
Yes, we can. So I think this has been known for a very long time. So this is not news. I know it's been approached a lot of the time as like this is a new thing. We've known that we can modify jaw and skull structures in general. And it's been looked at, for example, in animals. If you look at the sutures that fuse the skull bones together, we've known for a long time that when you apply tension to sutures, as in you slowly separate them from each other, what happens, the sutures are interlocked like that. As you apply that tension leads to bone generation into that area, and so the bone can become bigger. And so, for example, you see children who develop problems with their brain and they have too much fluid in their brain, they will have what's called hydrocephaly, and their skull
actually, the bone
becomes quite big.
Right.
And kids who have problems with the sutures fusing prematurely will have what's called synostosis syndromes, will actually have smaller structures for that exact same reason. So we've known that changes can actually modify the way the bones grow. Not all bones can be changed, but we know that bones that are connected to sutures are open to that change. And the upper jaw happens to be one of those.
Very interesting. So, and hence it impacts the way the soft tissues are supported. Is that a fair enough statement?
Well, the soft tissues are supported by the bone. So obviously, let's look at the nose, for example. The nose is part soft tissue and there's cartilage as well. So that's neither soft nor hard, it's somewhere in between. And then you have the bony structure, which is the deeper part of the nose. So let's say the lips at the same time. The position of the lips is highly impacted by the position of the front teeth. That's why if you see somebody with no front teeth, they're going to have very poor lip support.
That's right.
So yes, the soft tissues and hard tissues, they have a very close relationship.
So in terms of the aesthetics of a face, so how a person looks, this is going to be very impactful. And part of orthodontic treatment, of course, me talking about, cosmetic dentistry, from point of view of cosmetic dentistry, of course, we straighten teeth for that beautiful smile. But we're saying that straighter teeth means that the palate has grown enough to accommodate the teeth so that they can emerge in more straight formation.
That is correct, provided the way this was achieved by what is actually done by a growth modification method. Because if we just move the teeth can move, and the teeth have their own little bony structure called the alveolar process. That doesn't necessarily reflect a growth in the jaw itself. So it's just changed. Let's say, for example, we use something like braces or aligners, the clear aligners. We're moving the teeth, but not necessarily creating a jaw growth change. In order to change the growth of the jaw, we actually want to target the bone rather than the teeth.
That's right.
And so we aim to expand or widen the palate, but by widening the jaw itself, not necessarily just the teeth.
Yes. And so the jawbone has grown enough to accommodate the teeth coming out in a more straight manner. But that on its own has a health implication, correct?
So yes. So let's say, for example, we're looking at the upper jaw as a structure. Now, ideally, the tongue should sit on the roof of the mouth, especially when we're asleep and we're breathing through the nose, and the air is passing through the nose. Now, imagine that this upper jaw is too narrow, it's really small, which a lot of the time doesn't have to always be reflected in crowded teeth, but a lot of the time the teeth are going to be a little bit crowded or crooked.
Yes.
So this upper jaw is narrow, which means the tongue doesn't have as much space to sit in the roof of the mouth anymore, which means the tongue is going to sit low and potentially a bit further back. It's going to be cramped in its space. And the tongue is a soft tissue. So that can sort of compromise certain functions. Speech can be affected by that because there's not enough room for the tongue, but also can impact the breathing to some degree, especially when the child is asleep and the muscles start to relax, and this can actually start to create problems in the back part. Now, we're looking at the other side. If we look at the roof of the mouth, well, if the roof of the mouth is narrow, the other side of that is the floor of the nose. So if the floor of the nose is narrow, which means we're breathing through a narrower straw or a narrower channel. Now, if we can change that, if we can grow the palate to become bigger, the side effect of that will be the floor of the nose area, or that base of the nose, becomes wider as well. So the opening of the nose becomes a little bit bigger as well. And I think the photos that you can see from here, this is, for example, before and after widening of the palate. You can see how as we've widened the palate, the aperture of the nose has also increased.
So that means less future implications as far as ear, nose, and throat interventions are concerned as well.
Well, so that is interesting you say that, because I always say it's a little bit more of a chicken or the egg situation. Well, is the problem that we have difficulty breathing because like enlarged adenoids, enlarged tonsils, and allergy, and then because of that, the child is ending up using their mouth, so the upper jaw is not developing big enough? Or is it the other way around? We don't really know exactly. We know that they're very closely linked together. I'll give you an example. Imagine if you are breathing from your mouth. If you just imagine what are the implications of mouth breathing. If we are sitting down now breathing from the mouth, the tongue can't sit in the roof of the mouth.
No.
Now, children grow a lot when they're asleep. Obviously grow in the day as well, but a lot of growing happens when we're asleep. Now, if we're sleeping with the mouth open and the tongue is sitting low, who's actually applying pressure to the upper jaw? The cheeks now are more present than the tongue. Now, the tongue provides a balance for the pressure that comes from the cheeks. Now,
Yes.
if we're breathing from the mouth. So gradually what tends to happen is the upper jaw doesn't develop to be the width it's supposed to be. Other people might argue, well, it's actually because of the upper jaw not growing that the kid is breathing through their mouth. Regardless of which way it is, we know very well from plenty of research now that once we expand the upper jaw and make it wider, there is a significant reduction in the resistance to breathing from the nose.
Yes.
There's many studies that have been done on that. And using rhinometry, so measuring how much pressure is actually required to breathe through the nose.
How fascinating.
That's very closely connected. So that's what we can influence.
You talked about resistance to air, what we call sleep disordered breathing or sometimes sleep disturbed breathing. So that is basically a spectrum that eventually sometimes in life might lead to sleep apnea. Maybe briefly talk about that. I know that, a lot of people are very interested in the sleep and how their children sleep. It's a common issue that we hear parents talk about. What is this phenomenon?
I mean, obviously, sleep is important for many, many things. And in children, it's super important because a lot of the impacts that we see on children during the day have a lot to do with what happens to them when they're asleep. So the spectrum that you're talking about, we refer to it as sleep disordered breathing. Some, obviously, on extreme, that is what we call sleep apnea or obstructive sleep apnea. But it doesn't have to be obstructive sleep apnea to be a problem. We need to maintain a nice oxygen saturation, and the air has to flow through in a certain way to keep us in that balance. Now, what happens to a lot of kids if they're not getting the amount of oxygen or quality breathing in their sleep, their body micro wakes them in order to get that air in. This is either going to happen by them moving around a lot in the bed, where they're trying to sort of, get into a better position to get better breathing, or they wake up slightly. Now, they don't wake up, we don't see it, but they wake up. So that sleep is low quality. So even though they might have slept for 10 hours, it's a very poor quality 10 hours. And so they wake up in the morning, and in an adult that suffers from that problem, those adults are mostly going to be tired. But kids are actually not like that. Kids will compensate really well. In fact, a lot of them are going to be hyperactive. Yes. So they can't sit still. You're going to find these kids who are just sitting in the chair. They can't sit still, can't focus at school.
Yes.
A lot of them are going to be on the spectrum for ADHD, when a lot of that has to do with what happens in their sleep. Some kids are going to be tired in the day, but it's not the most common presentation. The other one is going to be maybe we can't focus on tasks for very long, or we get a delay in speech. All these things that happen in the day are a reflection a lot of the time on a bad night's sleep. Now, this is one night. I'm talking about consistently getting poor sleep because we're not able to breathe well.
I know that the rate of prescription of Ritalin, which is a drug used for ADHD, has spiked in the recent years in Australia. And I've always wondered whether our children's sleep are progressively getting worse because of, the modern diet or the use of, devices and things like that. So it's very, very interesting that you're explaining this as sleep related, because a lot of parents might not even think that, that might be the issue. We always think that a hyperactive child has had a good sleep and that's why they're so energetic. But, the drug is a central nervous system stimulant and is waking them up so that they can function.
The one thing is here, the thing is, the puzzle is a lot more complicated than we think it is, because let's say we're looking at sleep disordered breathing as, now we're adding other factors into it nowadays as well, because kids are watching, they're on screens late, so that's going to disturb melatonin secretion. They're going to be, if they're prescribed any stimulants, then it's also going to be impactful. But a lot of kids are not on prescription and they're still having these issues. It's because it's all a piece of the puzzle. It's the diet. Could be the diet, could be the fact that they're having too much sugar, too much food coloring. So it's very hard for us as an orthodontist, because we also have a particular scope we work with.
Of course.
So we normally like to also pull in other specialists to work with.
Very important.
And you're going to find that once a lot of those children end up, we diagnose them that there's a problem. I know that there's a problem. I sometimes can't pinpoint I can see that there's a narrow upper jaw, but most of the time what I tell the parents is the narrow upper jaw is just one piece of the puzzle.
Very true, yes.
We can't just fix that and say, I'm going to give you an expander or an appliance to help your jaw develop, and now I'm going to fix your life. It's actually not, that would be not correct, because
it's not a miracle cure.
Exactly, because this is only one part. The airway is a big pipe, and the child is an entire being. Exactly. Yes. So I normally say, ideally, we want to also involve a sleep physician, because a lot of the times the findings in those sleep studies are eye-opening, and we realize, you know what the problem is? All this airway blockage, whatnot, is actually coming from silent reflux, or they have actually some gastrointestinal problem that is leading to the disturbed sleep, and so on.
That's right.
So
because reflux can increase mucus buildup in the upper respiratory tract anyway.
Exactly. And
correct.
So, and you get all this blockage in it's actually irritation coming from that reflux.
So it's really, really important. I mean, I'm a general dentist, you're an orthodontist, and we are talking about health. And it's really, really interesting, because now we are seeing how intricately connected this system is. So we can't really practice this in silos. We have to have this dialogue between the different disciplines. And this is always my message to parents as well, that, you know, you do need to see the ENT, you do need to see the sleep physician, the orthodontist, you know, and get this team behind the health of your child. But at the end of the day, you are in the driving seat here. You know, the main responsibility of health happens at the lifestyle and the family level.
Absolutely. And I think one of the things in today's, what we are learning from each other, is that correcting one aspect is good, but we need to not forget looking at the other aspects of the same problem, I guess, in a way. So when we're looking at children who are growing, we want to start looking at certain things quite early and getting, like, let's say I'm an orthodontist. So people come to see me because they have crooked teeth. They don't come to see me because they're not breathing well.
Yes.
But more recently, we're getting some of that happening. So they come to see us and say, like, you know what? You're not breathing well because your upper jaw is narrow, but your upper jaw is narrow because there is also other aspects to it. Sometimes the adenoids are blocking the airway, so the kid can't use their nose properly.
So they have to be mouth breathing.
Exactly. So
there's no other way.
And we can't put a plate in a kid's mouth like that and expect them to get a response, because the blockage is actually coming from somewhere else. Or they could have an allergy, and no matter how much we expand the nasal airway, the mucus is going to build up and it's going to block it. So we like to make sure that we pick it up, because what we can do is we can see the problem. I can see a symptom, like the crooked tooth, narrow upper jaw. Great. Okay, so there's potentially, not always, but potentially a breathing problem related to this. We start to ask some questions. What does your child look like when they're asleep? Oh, they're open and they're like that. Do they hear them snore? If they hear them snore, that's not normal. Children shouldn't snore. Oh, but everyone in our family snores. Okay, well then everybody in your family requires some attention. It's not because it's or we're all a bit nasal.
And it's not cute for a child to snore.
Exactly. No, it's not cute for anyone, really, is it? So that's one thing. The other one is, what are they like in the day? So the parents can actually pick this up. A lot of parents will come and tell us, oh, you know, my child is really grinding very heavily in their sleep. I can hear them grinding their teeth. Well, that's one of the signs. And once a child ticks a couple of those boxes, like, oh, they grind heavily in their sleep, but
they're tossing and turning, they're sweating.
Or night terrors. Night terrors is a common one. They wake up terrible dream, or their mom and dad's room every few hours because they've had a bad dream. That's actually a sign of sleep disordered breathing. There's something wrong. And bedwetting is also one of those. Yes,
yes. In fact, there are a number of sleep questionnaires that are readily available online, and I encourage parents to just, you know, have a look at these questionnaires and just inform yourselves. And if you see that there are some signs that requires a bit more investigation, then we have, you know, people that we can refer to. Unfortunately, you know, I mean, sleep physicians are, you know, very, very busy. We only have a few in Adelaide, and their waiting lists are very, very long. And a lot of these kids basically are not treated in time. But I think that awareness also makes a big difference in the life of the child. So I think from what you're explaining, I can see that we can influence growth. So it's not all genetics. We can't just say, well, this is the way it is. We'll wait until, much later and we deal with it. Maybe we'll have some surgery when they're, past age 20, etc., which is very traumatic. My passion is to prevent things from happening much, much earlier on. And I've always wondered, an infant who is an obligated nose breather because they have to breastfeed, at what point they become mouth breathers. So this is something that I talk about with patients. Watch the mode of breathing of your child, even train them to become nose breathers. Do you think that we can train our children or influence our children so that they grow on a better trajectory?
I think we can, to a certain degree. What I encourage parents to do is, I think the first thing is to actually be aware of what are the signs that there is a problem. Like, is my child developing normally or not? Well, when we, for example, look at the primary dentition or the baby teeth, when the baby teeth comes through, there should be some gaps between the teeth.
Mm-hmm.
So looking between the front teeth, there should be some gaps between the front teeth.
Yes.
And the reason there are gaps are necessary is because the adult teeth that come through later are actually quite large. So
bigger,
children who don't have gaps between their teeth, it's usually a sign that there's probably going to be some potential problems in the future. But that also sends a signal that the upper jaw is potentially a bit small. And if the upper jaw is a bit small, we know there's other parts linked. The other side of the upper jaw, like I said, is always the nose. Having gaps between teeth doesn't necessarily mean they're going to have straight teeth later, but at least it means that we're in that, in that normal side. So when you see a child with no gaps between the upper front teeth, they're in their primary dentition, it might be an opportunity for us to have a bit of a look and see, well, what's going on with, are they breathing okay? Is something else going on there?
Yes.
How do they bite together? Because it's very rare for children to have what's called an underbite, so the lower jaw being wider than the upper jaw or more forward than the upper jaw. And that's very easy to change and correct in children who are under the age of 8, 9 years old. The younger they are, the more we can do to modify the growth of the jaw. And in fact, what you're saying about surgery, there's been a recent randomized clinical trial, not that recent anymore, about 8, 9 years ago from the UK, which showed children who had upper jaw expansion and development done before the age of 10 had a much greater, 2/3 of these children were classified as not needing any surgical intervention, whilst the kids who never had that intervention and had the same bite problem, more than 2/3 of these kids were considered surgical candidates when they got to the age of 18. So we know that jaw growth modification in kids works, and it prevents complicated treatment in the future.
So important. I'll be actually interviewing an oral surgeon, Dr. Baba, soon, to just basically talk about these surgical procedures, because first seminar that I went on and had a look at them, I thought, I don't want this for my patients, for my loved ones, or my friends. So it's really important to prevent those. You spoke about the underbite, and this is really, really important because, we see children have habits, dummy use, finger sucking, and also the narrowing of the upper jaw because of, say, for example, mouth breathing. Is it fair to say that if the upper jaw is narrow, it won't allow the lower jaw to develop forward to its potential and create that receded chin or receded mandible?
There is a relationship, but it's not a direct cause and effect. The reason I'm saying that is because there are kids who have this problem and who don't have lower jaw growth problems, while others do. And why some develop it and why some don't, we don't really understand why. But what we know, for example, is there's a really good study done in Scandinavia. I can send you the reference to it. But what they did was they looked at kids who were normal growers and kids who looked like they were developing what we call the long face or the adenoid face, which basically signifies problems breathing through the nose. They're mouth breathers. And those
forward
kids
neck posture as well, that comes with that, yes.
So, and a small lower jaw, etc. And those kids, before the age of 5, they actually had tonsils and adenoids removed, and the breathing situation was corrected. And then they looked at those kids 5 years later and compared them to the controls who were normal to start with. And they found that over the 5 years that followed the correction of the breathing problem, their growth patterns normalized. So I don't know if it's necessarily the bite as such, but maybe also just the overall function getting better that can do that. Genetics, however, does play a role.
Of course.
And
yes.
so, for example, when we were looking at an underbite situation where the lower jaw is large, that tends to run in families.
Yes.
So we have technology now where we can actually really make a big impact in underbites, especially using the new sort of titanium plates, etc., which I can elaborate a bit later on. But we know that the genetics of the lower jaw is one of those things that's not so easy to change. So we can change things, but some things, this is why families look alike.
And this is why you guys are there, to correct these issues, because again, what you're talking about is underbite, which means the lower jaw actually sits forward of the top jaw. And aesthetically, it's a big issue. And often when people have finished the window where you can modify growth, then they require surgery. But, so with correct intervention, you can bring the top or the mid face forward and rectify the issue. So again, goes back to, we shouldn't really miss the boat on when it comes to orthodontic treatment. I've always said to patients, go early. Even if the orthodontist says, that's fine, we're not going to do anything for 2 years, at least we know when we're going to intervene and not miss those milestones.
And you know what, that appointment that you say, we tell you come back in 2 years, this is actually for us, it's actually quite a good thing to see a child at an early age, even if we don't treat them. And the reason is, imagine you walk in at age 12 with a particular problem. Now, I can only guess how you got there.
Right, yes.
It's like when you look at a picture of a car.
Yes.
You have no idea how fast that car is traveling. But if you want to measure the speed of a car, you got to see it at 2 different time points.
Yes.
And so when I see a child who's potentially developing a bite problem as an orthodontist, they come to see me and they're age 7. And I think, like, you know what?
Let's wait on it.
Let's wait for a year and I'll have a look in another year. And then if I see in a year, okay, things are getting worse, okay, well, it's time to intervene. But if they turn up and they're already 12, well, we kind of a little bit, we don't know. Like we can only guess this is potentially how this got there.
Thank you so much. That's really, really useful information. Thank you, Dr. Nour. Is there anything else that you would like to add?
Well, one thing I would probably want to add is looking at particular interventions to help growth modification. And so when we're looking at upper jaw growth modification or any form of growth modification, I would strongly recommend that patients do enough research and see a specialist who specializes in that field and has a passion for it. Because growth modification works. It's just got to be done the right way.
Yes.
So that's my area of, like, I'm particularly interested in it. I do a lot of upper jaw growth modification. I hear from patients a lot that go, we've tried this method, we've tried this method. Ideally, we want to go with something that you find has been published. There's literature available and there's evidence there on it. And see a specialist who knows what they're doing in this area. Because there's a lot of things that are being sold online, devices that people can buy, and things that come in small, medium, and large sizes. Ideally, if we're going to use something in your mouth, you want it to be made for your child. It's going to be custom made for that particular child, custom made for that particular bite. That way, the child is likely to feel comfortable wearing it. It's likely to work.
Fascinating. And this is why you're here. You're actually a speaker at the national forum that orthodontists have in South Australia. And that was the topic of your conversation with the orthodontists today.
Yes. So what we were talking about was new technology in jaw growth and upper jaw growth modification.
Yes.
Without becoming too technical about it here. But what we know is the jaw deficiency, upper jaw deficiency, is a bony problem. Like, it's a problem in the size of the jaw. Now, for a long period of time, the only way we could access the jaw was through the teeth. So we would fit a device on the teeth in order to try and modify the way the jaw is growing. The teeth were our anchors.
Yes.
Now, about 15 years ago, the technology of what's called a TAD, or a temporary anchorage device, has been introduced, which is basically using small titanium pins.
Screws.
Or screws. We prefer to use the word pin.
Pin.
Okay, so that's confronting.
Sure.
And those, we can place them in strategic places in the jaw, and that way we can actually really influence the base of the jaw. And what we're finding is the results definitely look much more promising and greater than what we are seeing coming from the conventional. And it doesn't say that the conventional appliances don't work so well. They actually work really well, but we're finding we can even get more bang for our buck.
So basically, for the benefit of our audience, I just explain it one more time. So these pins sit on either side of the suture that you were explaining before, which means that they bear the weight of that expansion rather than the teeth, which means that our nose is going to be more patent because the movement is coming from the center of this bone rather than the edges of this bone. Correct?
Exactly. What's important to understand is the children actually, this is not a painful exercise for kids. I've got 2 girls, 2 daughters, both had underbites and small upper jaws, and I've treated both that way. And we've treated hundreds, if not a couple of thousand kids with that method now. And it's not a scary thing. It's not a scary thing. But by placing the pin the way we place it in the roof of the mouth, we then mount the device to that area. We can get the widening where it's needed, which is the base of the jaw. That's good for the teeth because it actually widens the base of the jaw for the teeth. But then it also has that great impact on the breathing,
on the nasal patency
as well.
And airway.
So that's why I'm telling you, the studies with rhinometry are showing that those bone-supported expanders in the slightly older children, we're talking about kids who are older than 9, 10 years old, those bone-borne expanders are producing greater impact on the nasal airway than even our conventional expanders were doing. So it's a promising area and it's very exciting to be involved in.
It's been an absolutely fascinating discussion with you. I should say to the audience that, schools of thought in orthodontics are varied. And of course, people are going to various orthodontists. And in Adelaide, we have a great group of professionals that are providing amazing care for their patients. If they are interested in one way or another, they can do their research and find the person that they trust, and that's really, really important. In terms of what age, I know that Prof. Ali treats much younger children when they have a diagnosis of sleep apnea, so later on in the year we will be speaking to him as well. But for now, thank you so much for taking time out of your very busy schedule today. Thank you.
Thank you for having me. It's been a pleasure.